We'd like to welcome you to this podcast with the Ogden Surgical Medical Society. I am Mark Johnson, and then our other interviewer is Steve Sharman. And we are privileged today to have Mariam Nassif, cardiologist from McCady Hospital, joining us for this podcast on cardiac imaging. A little bit about Dr. Nassif. She is a general cardiologist at McCady Hospital with a subspecialty in cardiovascular imaging, including echocardiogram and vascular ultrasound, nuclear cardiology, cardiac CT, and cardiac MRI. She joined McCady Hospital in 2006, and this is her 15th year at McCady Hospital. She's originally from Cairo, Egypt. She came to the U.S. as a foreign exchange student her senior year in high school, and then later did an internal medicine training in Rochester, New York, and cardiology training in Philadelphia, and then went on to cardiac CT and cardiac MRI training in Washington, D.C., Philadelphia, and Columbus, Ohio. She has been a staple in the community here in Ogden and has been a pleasure to work with over the years. And so Steve and I are thrilled to interview Mariam Nassif, and we'd like to turn the time over to her.
Thank you very much, Mark and Steve, for having me as part of this podcast. I have no disclosures relating to the topic that we're discussing today. The topic of this podcast is cardiac imaging. And as a cardiac imager, it has been an amazing field to be in because of the major strides that happened in this field over the last 15 to 20 years. And I hate to date myself, but when I graduated from fellowship in 2003, the landscape for cardiac imaging was very different than what it is right now. There has been leaps and amazing advances over the last 15 to 20 years. When I think of cardiac imaging modalities, I think about them as tools in our toolbox. And my job today is kind of to familiarize everybody with those tools. What's the strength and weaknesses of these modalities, and how can we utilize those tools to help us achieve our goal, which is basically clench the diagnosis and help the management of our patients. When I thought how to approach that, I thought that there's a few scenarios that are very familiar to all of us that see patients. And these scenarios, we see them day in and day out. And I thought that we might just talk about those different scenarios and how we can approach those cases and how can cardiac imaging help us in those situations. The first scenario is an asymptomatic patient that walks in our office and has multiple risk factors for coronary artery disease, including high cholesterol, high blood pressure, maybe prediabetes or diabetes, and is concerned about the risk for coronary artery disease. Or maybe an asymptomatic patient who does not have as many of the risk factors, but certainly has an ominous family history of a father having heart attack at age 40, or a mom that had an MI at age 50, or a brother that's younger with a couple years but just presented with an acute MI, and they are concerned and anxious and frantic about their risk for coronary artery disease and NMI. And another possible scenario would be this young patient with familial hypercholesterolemia that is well aware of the cardiac history in their family because of this issue. They're maybe in their mid-30s and they're concerned about what is their situation? Do they have coronary artery disease? How the risks to develop it and what they should be doing at that time. And so this patient who's coming in and saying, what is my risk for coronary artery disease? What is my risk for having an MI? And it's hard these days to justify to the insurance company doing tests on an asymptomatic patient. And so justifying having a treadmill exercise test or any form of stress testing in somebody who's totally asymptomatic is a little bit tricky. The thing that has gained quite a bit of momentum in the last few years has been coronary calcium score. And it's interesting because coronary calcium score came into existence in the late 1980s and early 1990s. And it took a very long time for it to get momentum and acceptance and high recommendation from the societies and be part of the guideline. And I think part of that has been the need for data. And over the years, especially in the last 10 years, we've had a plethora of data that corroborated that this is a very excellent test to help us determine risk. For the longest time, when we had a patient asymptomatic that's coming in and asking us about the risk for cardiovascular events and so forth, we've always just pulled up our Framingham score calculator and just, put in all of the patient information and came up with a score and just kind of categorized them into low, intermediate, or high risk and basically gave them the risk for cardiovascular events based on the Framingham risk score. But we have came to realize with all of the new data that there are a lot of patients that do not fit nicely into the Framingham risk score. And so the risks by the Framingham score calculator is not necessarily as accurate as we would like it to be. And that's when calcium score really came into play. And just a small introduction about coronary calcium score. This is a non-contrasted gated CT scan. So basically, we just, without any contrast, just take an image of the chest, and the calcium appears like a white chalk on the background of black, which is the arteries of the heart. And if we see that, then we know there is calcification present in the coronary arteries. And what I tell my patients is that if you have a normal artery with normal arterial wall, there is no place for the calcium to deposit. In order to have calcium deposition occur in the wall of the artery, you have to have plaque deposition. That is the place where the calcium deposit inside the wall of the artery. So patients are kind of thinking like, so does it mean when I have calcium on the arteries of my heart that I shouldn't be taking calcium supplements? Is that something because the calcium in my body is higher than normal? And I try to explain to them that our interest is not necessarily in the calcium in the arteries. Our interest that it is a surrogate for plaque burden in the arteries of the heart. And so once we see calcification, we know there is plaque burden. And the more calcification we see, this is indicative of a larger plaque burden. And so the idea is that if you have a high plaque burden, then your risk for developing cardiovascular events goes up exponentially. And it's very interesting because diabetes is felt to be a CAD equivalent, and it increases your risk for cardiovascular events by about threefolds. But when you have extensive plaque burden on a coronary calcium score, there are some studies that are quoting an increase of 9 to 12-fold in cardiovascular events. So it certainly is very powerful when you have extensive plaque burden on the coronary calcium score. And when Dr. Agustin came up with the coronary calcium score, he wanted to have an objective way of dividing people into minimal, mild, moderate, and extensive plaque burden. So they came up with numbers to kind of put people in the different buckets. So if you have minimal plaque burden, that means you have 0 to 14 as a calcium score. If you have 15 to 100, that's considered mild plaque burden. If you have 100 to 400, that's considered moderate plaque burden, and more than 400 is extensive plaque burden. And certainly when you lie in the extensive plaque burden, you are at increased risk for having cardiovascular events. And the reason behind that is that there is a misconception in the mind of the public that if you have heart attack or a myocardial infarction, this means that you have to have a very tight blockage in the arteries of your heart to be able to develop a myocardial infarction. But there has been a meta-analysis that was performed many years ago that looked at studies of patients who presented with myocardial infarction and looked at the underlying stenosis that the myocardial infarction occurred upon. And there has been a very wide range of stenosis. So anywhere from 10% to 90% has been the underlying stenosis for patients who developed myocardial infarction. So it's certainly not the degree of stenosis that is the nidus for the myocardial infarction, but it is the plaque disruption or the plaque rupture that occurs. So it's not the stenosis severity, but it is the plaque itself. And whether you have a vulnerable plaque or not is what determines if you develop myocardial infarction. And the way I explain it to my patients is that I tell them, you can think about it when you get a small wound on the surface of your hand. The body tries to take care of that wound by laying coagulation factors on it to try to prevent bleeding and to take care of that wound. The body thinks the same way when there is a little ulceration of that plaque. It sees it as like that wound on the outside of your hand. It sees it as a wound inside your artery. And so what it does, it comes and try to put a little bit of clot on top of that to try to heal it. But clot begot clot inside your artery of your heart, and all of a sudden you block off that artery and cause a heart attack. And so the idea here is to determine who has that vulnerable plaque, because that's what will tell us who has that predisposition to get a myocardial infarct. And there has been a lot of things that has been thought to be a possibility for identifying what's a vulnerable plaque is, but certainly nothing that came into the clinical realm and has been very helpful and very effective. And so the way I tell people is that if you have extensive plaque burden and you have a lot of plaque everywhere in your arteries, any and every one of these plaque could be a potential plaque that can ulcerate and cause myocardial infarction. That is why if you have extensive plaque burden, that you have several-fold increase in developing a myocardial infarction, because these plaques, any one of them could potentially be a vulnerable plaque, and we certainly don't have a very great way of saying this is a vulnerable plaque or not. We have, different criteria that the different modalities try to come up with, but none of them is the gold standard that we're able to tell you, you have a vulnerable plaque and the person sitting next to you does not have it. So I think the strength of the coronary calcium score comes in determination of those with extensive plaque burden, because we're more vigorous in treating them medically, but also in determining how tight the blockages that are caused by this extensive plaque burden. And it doesn't work as a one-on-one kind of relationship. So if you have extensive plaque burden, this means that you're going to have very severe blockages. It increases your chance of having severe blockages, but it's not a one-to-one relationship. And the Society of Clear Cardiology came up with the recommendation, together with the Society of Cardiac CT, that if you do have coronary calcification of 400 or above, that's a good reason to do a hemodynamic testing or a stress testing so you can understand the degree of severity of the stenosis that is caused by these plaques. And so anybody that has an extensive plaque burden or a calcification of more than 400, we certainly should be proceeding with a stress testing for those. Now, the other strengths of the coronary calcium score comes from the zero calcium score. So if you have a zero calcium score in a patient that is completely asymptomatic, your risk of having significant coronary artery disease is less than 5%. So you have a 95% chance of not having significant coronary artery disease. And you have a 5-year risk of having cardiovascular events that is minuscule. So when you have a zero calcium score and you are completely asymptomatic, we tend to assure the patient in a big way that things are okay. Now, like everything in medicine, everything always have a little caveat there. And one of the caveats that I try to tell people that if you are below the age of 50, you may have soft plaque that does not have any calcium in it. And so this is where that 5% comes from, that you may have soft plaque with zero calcium. In patients above the age of 50, I have seen it happen where they will have soft plaque that has no calcium, but it's a much lesser group of people than if you are below the age of 50. But certainly, even above the age of 50, you cannot completely give people reassurance that having a zero calcium score means you do not have any, plaque buildup, but you certainly have a 95% chance that you don't have any major plaque buildup or significant coronary artery disease. In between the 0 and 400, it's still useful, but certainly it's useful to kind of sway us to give those patients statins and ACE inhibitors and even aspirin at times. I tell people that there has been studies that said in primary prevention, aspirin may not be, the risks may outweigh the benefit, and that has been all over the TV and all the patients keep asking about it. In people who already have plaque deposition and atherosclerosis in the coronary arteries, I feel that this is more of a secondary prevention rather than a primary prevention, because now we can visualize that they have atherosclerosis in the coronary arteries. There have been guidelines that said that if you are 100 or above, that's a good, place to start statin. And if you're less than that, it's a conversation between you and your patient to decide that if you want to start them on statin or not. I have to say, I try to be more aggressive and push them towards a statin, even if they're less than 100, as long as they have plaque burden, because I feel that the earlier we jump on that, the better we're going to be able to help those patients. And we all are faced with patients that come into our office and say, I do not want to take a statin because of all the side effects that it causes. They will cite you that it causes dementia, that it can cause diabetes, that it will causes all the muscle aches and pains and they don't feel well with it. So certainly having a coronary calcium score make the conversation easier when you want to talk to them about putting them on medications, and they're more attentive to what you have to say, and they're more willing to take the medicine. And I tell people that I want you to know that even if we find a severe blockage and we take you to the cath lab and put a stent into the artery of your heart, that does not mean that we are saving your life by that, because there's that misconception that stents save lives. And in stable angina, it does not necessarily save lives. It actually improves symptoms. It helps the people increase their blood flow to their heart muscles so they don't have pain, and they can do more, and they can exercise better, and it increases their exercise capacity, but it certainly does not save lives. And I think it's important to tell the patient that, because what we put a stent in is when you have a stenosis of 70% or higher. And as I mentioned earlier, you can have a stenosis of 10%, and that ruptures and causes an MI. So it's very important that the patient realize that even with the stent inside there are plaque elsewhere in their arteries of their heart, and any of these plaque can rupture and cause an MI. And so what really decreases the risk of myocardial infarction is the medicine, not the stent. It is the lipid-lowering medication, it is the ACE inhibitors, it is the aspirin, it is the medical therapy that stabilizes the plaque and change it from a vulnerable plaque to a stable plaque. And that's what decreases the risk for myocardial infarction and basically save lives. Now, I think that if in those type of patients, when we actually address it by the medications and kind of give them their risk as, okay, you're in the 0 calcium score, your risk of having a cardiovascular event is very minimal, or you're in the extensive plaque burden, your cardiovascular event rate is very high, we need to be more aggressive, we have to work really hard on getting your risk factors under control, we have to actually evaluate the hemodynamic significance. And in the medium, it's kind of that minimal, mild range, moderate range. I think definitely treating them makes sense with medications to decrease their risk factors, but their cardiovascular event risk is not as bad as somebody who has the extensive plaque burden. That's pretty much what I normally tell my patients who come in asymptomatic and want to know whether they have coronary artery disease, and the coronary calcium score will basically solve that problem for us. It's different from what we used to do with the Framingham risk score, where we are giving them an estimation of the risk. But with the coronary calcium score, we actually visualize the plaque, and with what we visualized, we kind of give them a better assessment of the risk.
I remember back to med school, kind of the life cycle of the plaque, starting with a fatty streak and ultimately ending up in a calcification. That process was described to me as being decades long to take, suggesting possibly that until it becomes a calcification or calcified, that it is reversible. Because I've got having similar conversations that you're talking about with patients. Their concept is that, well, if that's the case, maybe I can reverse what I have in the immature phase before it's calcified by lifestyle changes, etc., and therefore I won't have to go on medications. Is that true?
You will find a lot of the statin trials that says there is regression of the plaque, but I believe that this is not something that we can visualize in any way. So even when we do the cardiac catheterization on people multiple times, we never see regression, even though we've gotten their lipid-lowering drugs to the max. We've dropped their LDL cholesterol really low down. I think the regression is not something that can be easily visualized. I think that's something that they may be able to detect it in research, with research tools, but in the clinical world, I have to say it's very hard for us to see that regression. And the way I tell people is that I don't know that I will give you a way to regress your plaques to the point that it will disappear. As it stands right now, we do not have a liquid Drano that we can just basically ingest and it just unplug your arteries. So far, we have not come across that great drug yet. But what we can do is we can stabilize that plaque. We can stabilize it in a way that it's no longer as big of a threat to cause myocardial infarction. You probably can get some regression in the early phases, but I don't know that we can see that clinically.
So, Dr. Nassif, question for you. This is really interesting. I'm curious, when someone comes in who's asymptomatic, who wants to assess their risk, and you order the CT calcium score, is there a criteria for recommendation on when to order this, what age, what risk factors are needed, and give us an idea of what the cost is and what insurance is typically covering for this now?
We order a few coronary calcium score, and there are certain insurances that allow us to do that, no questions asked, but there are other insurances that are very difficult to have them basically give us approval for that. So this is variable from insurance to insurance. We will always prior authorize those tests, and even if we do not do it in our office, radiology will do it. So they will not do the test unless they prior authorize the test with the insurance. What happened and you are all aware of that now almost every hospital is offering coronary calcium score with a cash pay. And there has been hospitals that have been really doing that with very minimal expense to the patient. So I'll tell you, when you send to the insurance a bill for the coronary calcium score, it's about $350, including both the technical and the professional fee for the coronary calcium score. So in the big scheme of things, it's not a very expensive test. I think their concern is that if they open that to everybody, that it will be just not necessarily the expense of each test, but the magnitude of the tests that they are going to have to do. And so some of the insurances have been willing to cover it, but not all of them do. In McCady, you can actually get the coronary calcium score as a cash pay for $89. Having said that, I'm sure there are other hospitals that are even doing it for cheaper. I've heard, $69. I've heard all sort of numbers. So I think if the patient is interested in doing it, there has been a lot of patients that are just going in and getting it done. And it's interesting because one of the patients that I took care of that had extensive plaque burden came to me with a coronary calcium score from a different hospital and said, one guy in our office did the coronary calcium score and it came back really bad. So we all got worried about ourselves and we all went and got the coronary calcium score. So, and it's interesting how that guy that came and saw me in the office had extensive plaque burden. We did a stress test for him, and sure enough, he had severe stenosis in the RCA and ended up getting a stent. So it's interesting how that this whole thing happened because one of their colleagues just decided to get it, seeing it on the billboard of one of the hospitals, and it ended up being something that this guy benefited from. Now, as far as criteria, I don't think that people who have no risk factors whatsoever should be getting coronary calcium score. But I think if you have multiple risk factors for coronary artery disease, if you have hyperlipidemia and the patient is actually not wanting to be on a statin and feel like they need more information to push them to be on a statin, I think that's a reasonable thing to do because it will alter the management, and so that's reasonable to pursue that. I also think that if you have familial hypercholesterolemia, that's an excellent tool. Because I will give you one scenario that I had this patient with familial hyperlipidemia. She was in her early 60s. She was having some symptoms and she came in, and because she was symptomatic, we went down the symptomatic route and found out that she had severe disease. And her daughter, who's 35 years old with familial hypercholesterolemia and is on maximum dose of Crestor, 40 milligrams, with her lipid profile not very well controlled, but she's on maximum doses of that. Zetia, she was on fenofibrate, she was on all the gamut and fish oil and everything, and came and saw me and said, I know my mother was found to have disease. I'm 35 and she's 65, but I want to be proactive and I want to start, working on this. And so I told her, okay, let's go ahead and get a coronary calcium score and see where you're at. And her coronary calcium score came back 1,500 at the age of 35. And we did a stress test for her, and her stress test did not suggest that she had any severe stenosis, but she had extensive plaque burden. And even though she's on all of these lipid-lowering medications, we decided to get her pre-approved for Repatha. And the insurance actually allowed us to do that because of how her cholesterol has been difficult to control, and in addition to all of that extensive plaque burden. And the reason we put her on Repatha in particular was that the only, one that was approved at that time, but now there are other medications that are in the same group that we can potentially use. I feel that coronary calcium score had been a game changer when you look at risk factor stratification, because you can have hyperlipidemia, you can have familial hyperlipidemia, you have diabetes, prediabetes, you have, hypertension. All of these are risk factors and certainly would be a good and reasonable reason to test people for with a coronary calcium score, but also premature coronary artery disease in the family is a very good indication to do a coronary calcium score as well. Whether you do that to every single person who has no risk factors whatsoever and is just concerned, I think those people have the option of doing that through just going to, the cash pay and getting it done. But I don't know that we as physicians can order those tests and have the insurance cover them.
So Dr. Nassif, you talked about mostly the patient who is asymptomatic, who has risk factors. What about the patient who presents with either typical or atypical chest pain, and now you want to do a test? Is there a role for doing CT calcium coronary scoring for that, or would you in that case go straight to a nuclear stress test or a PET scan or a treadmill test? What's your opinion on assessing the person with typical or atypical chest pain?
The symptomatic patient who is coming in with either chest pain or shortness of breath, which is considered an angina equivalent, I think having a coronary calcium score alone would not be very helpful. The reason behind that is when they looked at people who had zero calcium score who has symptoms, they found out that actually you can have severe coronary artery disease or have even acute coronary syndrome if they present to the emergency room with chest pain, that just doing a coronary calcium score, you will miss some people who have severe disease or will have actually acute coronary syndrome. So the strength of the coronary calcium score lie in the asymptomatic group of people. In the symptomatic group of people, I don't put as much weight on the coronary calcium score, I use it in conjunction with other modalities, but not a standalone modality. So when you have a patient who's coming in symptomatic, the question that is posed here to us is that chest pain or is this shortness of breath coming from my heart or has a cardiac etiology, or is this caused by something else? And the idea here behind stress testing is that if you have a stenosis that is 70% or higher, you decrease the myocardial blood flow to the heart, and if that happens, the body perceives that ischemia, and it gives us the warning as chest pain or shortness of breath. So the chest pain or the shortness of breath becomes our alarm system that tells us that there is ischemia there. But if you have a stenosis that is less than 70%, the myocardial blood flow will not be impacted enough to cause chest pain or shortness of breath. So this is why they came up with the stress testing, because stress testing is able to detect stenosis that are 70% or higher, and that is why it can tell us if there is myocardial ischemia or not, and if there is myocardial ischemia, then the cause of the chest pain is cardiac. Now, you all I'm sure have heard from patients telling you, stress tests are not really good. I know this friend or this neighbor or this brother or the father or whatever that had a stress test done, and the stress test told them that there is no evidence of ischemia, and 1 month later or 2 months later they developed a heart attack. So these stress tests don't help, and they don't tell us exactly what's going on. I don't believe in them. And my feeling about that is that the stress test is supposed to tell us if there is severe stenosis that is 70% or higher. So if there is myocardial ischemia, the stress test should be able to pick that up. But as I mentioned before, myocardial infarction can happen on the background of any stenosis, which is as low as 10% as high as 90%. So if you have a stenosis of 10% or 20%, your stress test will be completely negative because your myocardial blood flow at the time of the stress test was normal. On the other hand, if that plaque decides to ulcerate and disrupt 2 months later, you will develop myocardial infarction with a negative stress test that happened 2 months before. So the way I tell people is that if you are expecting me after giving you the stress test results to tell you what your risk of myocardial infarction, I think I am not going to be as accurate as telling you if you have decreased myocardial blood flow at this point and that your chest pain is coming from that. So I just wanted to throw that in because I know that we are faced with that scenario quite a bit. And I get that from my patients quite a bit. The stress test does not detect what is going on. I've heard of people that it has missed, and I don't want to do a stress test. I think if the question that we are being asked is, I have chest pain or shortness of breath, is this caused by a cardiac etiology, which is ischemia and decreased myocardial blood flow? By all means, a stress test will be able to answer that. But if your concern is that I'm going to be able to tell you your risk of myocardial infarct when you have that test, we will be able to tell you you're in the low risk, medium risk, high risk, but we can't completely just rule out that you will have a myocardial infarction because you had a negative stress test.
That may be a good segue to not all stress tests are the same, and oftentimes we're left wondering which one should we order? And maybe it's based on the scenario, like you're describing, that certain people would do better. Maybe at some point you could just talk about there's a whole plethora of them. Which ones are used for what cases, or what do you prefer?
So the way I think about it is, if the patient can exercise, I will use a modality that has treadmill as part of it. And the reason behind that is stress testing with treadmill give you an immense amount of information. It gives you the blood pressure response to the exercise capacity, which in and of itself is a prognostic tool. If somebody can run on the treadmill for 13 minutes, even if they have severe disease, their prognosis is really good. Versus somebody who's on the treadmill for 2 minutes and can't do anything, that prognosis will be bad regardless of whether the test come back positive or negative. So I think that having the exercise capacity, the blood pressure response to exercise, any arrhythmias with exercise, any oxygen drop with exercise, all of these things are valuable information that the treadmill gives you. And it really gives us the ability to prognosticate this patient's outcome in a major way. So the way I think about it, can the patient exercise or not, is the first question that you have to ask yourself. If the patient can exercise, then the next question is, do they have a normal EKG or an abnormal EKG? If they have a totally normal EKG and they can exercise, then I think it's very reasonable to proceed with a treadmill exercise test. It is not as sensitive and specific as the more elaborate testing that we have, but it's certainly a very good screening tool and a good starter. If you do that test and it comes back negative, and the patient had excellent exercise capacity for age and had no arrhythmias and had good blood pressure response and had everything looking, great, then you can simply just say that chest pain is not coming from a cardiac etiology or a myocardial ischemia, and the exercise stress test cost $500 to the insurance. That's including technical and professional fee. So certainly a very inexpensive test and can help us just sort things to start with. Now, if we look at the sensitivity, specificity, and accuracy of the stress test, it's in the 70% range. So certainly it's not the most accurate, sensitive, and specific test, but it's a good start. And if that comes back abnormal, we certainly will do more elaborate testing and kind of try to go down the route of more sophisticated stress testing. Now, if the patient has an abnormal EKG but can exercise, we look at what abnormality we see on the EKG. If that patient has a left bundle branch block, a pacemaker, an ICD, that patient should not be exercised. And the reason behind that is that you get a lot of false positives when you have that patient exercise on the treadmill. When they exercise, their septum tend to move in a very vigorous way, and that gives us stress echo abnormalities. It gives us actually nuclear imaging abnormality if you use a treadmill nuclear stress test. So anybody that has a left bundle branch block, a pacemaker, so paced rhythm, an ICD, we basically channel them to a pharmacologic stress test with a LexiScan or an adenosine based, pharmacologic stress test. And this is to avoid false positives in this situation. If their EKG is abnormal because they have a WPW, a left ventricular hypertrophy, STT changes of 1 millimeter or more, then we say, okay, you can still exercise on the treadmill, but I cannot depend on having a treadmill exercise test where all that I have is the EKG, and if it's abnormal to start with, I don't know if it changes even more. I don't know what that means. Is that because you had an abnormal EKG to start with, or because you actually have, severe stenosis that is causing myocardial ischemia? So at this point, I need something else to look at other than your EKG to make that determination. And that's when imaging becomes important. Now, there are a whole slew of imaging modalities that we can use in conjunction with the treadmill stress test. We can use treadmill echo. We can use treadmill nuclear SPECT imaging, which we call treadmill cardiolite study. There are treadmill MRIs, but we don't have that available to us, and that's more of an investigational tool. But again, just so that you know that exists, but it's not making its way yet to the clinical world. So right now, the two ways that we can do it is either a treadmill echo or a treadmill nuclear stress test. Now, with the treadmill echo, the advantage of having treadmill echo is that it's a very specific test. It has a good specificity. And when we say a good specificity, this means that if I have low suspicion that this person will have coronary artery disease because they have not very many risk factors, you want a good negative test, a good test that is very specific, that will not just give you a lot of false positive. And that's where stress echo has a stronghold. So the way I use it, and that is purely my opinion, because you will find people using stress echo in a lot of ways, but I find it to be very useful in my practice in women in particular that are in their childbearing period and early into their 40s. These are patients that can exercise, and if they have a normal EKG, I would rather not do a lot of radiation in that situation. I want to avoid radiation because the breast is still vulnerable for radiation. So I tend to do a lot of stress echoes in those age group and in those population of patients. And stress echo tend to be excellent in them because you get the EKG portion, you get the imaging portion, you get the specificity of the test, and you don't get a lot of false positives in those people. On the other hand, if I have a patient who have a lot of risk factors, so if they have hypertension, hypercholesterolemia, pre-diabetic or diabetic, they're a smoker, they have family history of coronary artery disease, these people have pre-test probability that is extremely high. So I want to have the most sensitive tests that will include as many as possible of the patients that have the disease. So I will choose treadmill nuclear in those people because the sensitivity of treadmill nuclear is much higher than stress echo. On the other hand, the specificity is not as great. So I just base it based on my pre-test probability. And the pre-test probability, that, as we mentioned, if you have a lot of risk factors, you have a higher pre-test probability, but also it depends on how convincing are their symptoms. So when we talk about typical chest pain for cardiac, typical chest pain, we talk about three main things that cause that. We have patients that have substernal chest discomfort that is precipitated by exertion and relieved by rest or sublingual nitro. If they have all three of these features, then they have typical angina, and their pretest probability is quite high. And if you add that to risk factors, then that person deserves to have a sensitive stress test that has a good ability to include patients. On the other hand, if you have a patient who has non-anginal or atypical chest pain, and the way we determine that is if they have 2 out of the 3, it's atypical chest pain, and if they have 1 of the 3, it is non-anginal chest pain. When we say non-anginal, it doesn't mean that I should just completely discard their symptoms, because there are people that come in with very atypical pains, and they have so many risk factors, so they still deserve to be having a stress test. But the way we kind of want to look at that if your risk factors are very low and your symptoms are atypical, you may want to consider a test with high specificity, such as stress echo. On the other hand, if you have a patient with multiple risk factors for coronary artery disease and having typical symptoms, that you would have that patient be tested by a highly sensitive stress test. And just to give you a sense, the sensitivity and the specificity of stress testing with treadmill nuclear stress test versus echocardiography, they both are very reasonable, but I think the sensitivity of the stress nuclear is higher and the specificity of the stress echo is higher. Now, if I have a patient that is needing a pharmacologic stress test, either because they cannot exercise or because they can exercise but have a left bundle branch block or a pacemaker or an ICD, then those people I will choose a pharmacologic stress test. And when I'm choosing a pharmacologic stress test, the majority of the pharmacologic stress tests that we do are either adenosine, Lexiscan, or dipyridamole. And in McCady, we exclusively do Lexiscan. And we do Lexiscan because it has less side effects and more tolerated by patients. So that's why we choose the Lexiscan to do our pharmacologic stress testing. You can do pharmacologic stress testing with dobutamine. The problem with dobutamine is that it gives a lot of side effect and it's not very well tolerated. So we tend to shy away from dobutamine unless there is a specific reason to use it. So for example, if you have somebody that has severe asthma that is on prednisone all the time because they're just having exacerbation after exacerbation, or you have COPD that has the same deal, or you have somebody who is on oxygen round the clock and just requiring very high amount of oxygen, then it becomes a little bit difficult to have that patient get a Lexiscan. Having said that, we have done Lexiscan on a lot of patients, and in the last 7 or 8 years, I can tell you we've given aminophylline to a handful of people because Lexiscan is such a short-acting medication. It lasts in the system for about 6 minutes. So in general, even if they have symptoms, by the time we're actually drawing the Lexiscan, they already had the Lexiscan get out of their system and were able to get away with it. There has been a few patients where it was harder on them and we had to reverse it with aminophylline, and that was enough. But every once in a while, there are going to be people that you feel shy about trying Lexiscan in, and we'll do a dobutamine cardiolite on those patients. But I can tell you that I cannot even think, just in my recent memory, of dobutamine that I have done recently on anybody. We use dobutamine echocardiogram for evaluation of patients with aortic stenosis for valvular evaluation. That is our biggest use for dobutamine echo in the cardiology world. We just use it to kind of help guide us whether this is true aortic stenosis or just basically not a true aortic stenosis, but it's aortic stenosis caused by somebody who has very low ejection fraction that the valve does not open because there's no oomph to the ventricle. And so we give them dobutamine to try to give that ventricle some oomph and see does the aortic stenosis improve. And that's our biggest use of dobutamine in the world of cardiology nowadays. But in general, we will use LexiScan. Now, you can use LexiScan with a SPECT camera, which we call LexiScan Cardiolite, or you can use LexiScan in PET-CT. And I will tell you something that I was very surprised to know. We tend to use LexiScan Cardiolite thinking that PET-CT is a much more expensive test, so that's why we want to cut on the cost, especially in this era of having the population health, and we want to be cognizant of the tests that we're ordering and how much that will cost. I found out that the LexiScan Cardiolite, the insurance is actually billed $6,000 for the LexiScan Cardiolite. On the other hand, the PET-CT, the insurance is billed $5,600 for that. So believe it or not, the LexiScan Cardiolite is more expensive than the PET-CT and has less sensitivity, specificity, and accuracy. So if you look at the accuracy of the PET-CT is 92%, and that of LexiScan is all comers 85%. And so I rarely ever order LexiScan Cardiolite anymore. Because if you have a test that is more accurate and less expensive, why would you even go to the LexiScan Cardiolite? So all of the LexiScan Cardiolite people that I used to do in the past were now channeling towards the PET-CT. Because PET-CT does not only give you a subjective evaluation of the imaging by just perfusion imaging, it gives you quantitative measurement of the myocardial blood flow in each coronary artery territory. So the way I explain that to patients, I say, we give you the radioactive isotope. If you have no blockages in the arteries of your heart, the amount of the radioactive isotope flowing down your LAD, your circumflex artery, and your RCA should be equal. Because you have no blockages, the amount of blood flow should be the same. If you have a blockage in your RCA, then when we give you a vasodilator like the LexiScan, that artery cannot dilate because it's stenosed from that blockage. On the other hand, if you have normal LAD and normal circ, they will dilate 3 times or 5 times their size. And once you have that dilation happening, then basically the blood flow into those territories of the LAD and the circ will be much higher, and you will start seeing a bright uptake of that radioactive isotope in the myocardial region that is supplied by those arteries. And that myocardial region, which is supplied by the right coronary artery, will appear dim. And so we will have that perfusion defect that we see in the territory of the artery that has the severe stenosis or the 70% stenosis. On the other hand, we also will have the ability to measure the myocardial blood flow at rest and after giving the LexiScan and see how the myocardial blood flow is. If the myocardial blood flow is actually decreased after we give the LexiScan and we see a dim area on the perfusion images, then we have 2 ways of telling us that this is truly a stenosis and not an artifact. That's why we have higher accuracy with PET-CT than with SPECT imaging alone, where we depend only on the perfusion images to tell us what we're dealing with. Now, the other test that we can potentially do is a stress MRI. And a stress MRI have the same accuracy as a PET-CT, And it's actually less expensive than the PET-CT. It's about $5,000. But, again, the PET is about $5,600, so not a huge difference, but it is a little less expensive. But what you have to know about stress MRI is that you give gadolinium. And once you give gadolinium, you are limited in patients that have a problem with dye. Because gadolinium, if you have a GFR less than 30, can cause problems with developing, calcification and fibrosis in the soft tissue. So anybody who has a GFR less than 30 is not a candidate to get stress MRI. Anybody that has an ICD or a pacemaker, it gives us a lot of artifact close to the heart muscle, so not everyone is a candidate to get a stress MRI if they have a pacemaker or an ICD. So stress MRI is a niche area. We use it if we are going to assess a patient with well-known coronary artery disease who actually has been evaluated by other modalities, and we're trying to assess both ischemia and viability in that patient to help guide us decide on the treatment option. So I think in the primary care physician world, stress MRI may not necessarily be something that you will think of right off the bat because it has a niche kind of utility. And we tend to use it in the cardiology world to help decide whether we're going to go after a certain artery or not, whether there's viability there or not, and whether we send this patient for surgery or not. So it kind of helps us on the management end of things downstream, not necessarily as a first line of testing. Now, there's one other thing that I haven't spoken about, which is cardiac CT angiography. And I think cardiac CT angiography can be of extreme importance in the right population. So if you have a patient which you are thinking that that's a young male with low pretest probability, but keeps coming back with having chest discomfort, you've done a stress test on, and it came back saying that it's negative, but they keep coming back and saying, I am still having symptoms, I think there is a problem there. You're concerned about the accuracy of the treadmill exercise test being only 70%, and you're worried about them and want to put this to rest. I think coronary CT angiography can be an excellent tool in this situation. Because if you actually get the coronary CT angiography and a 0 calcium score and there is no plaque visualized at all on the coronary CT and they have normal coronaries, no anomalous coronary artery disease, you can reassure that patient and tell them that I think your risk of having any problem from coronary artery disease is minimal at this point. On the other hand, for example, if you have somebody that you think it could be typical chest discomfort, but this is a young patient, I don't know that this patient is basically having cardiac pain or not, I have used coronary CT angio on those young men as well. And I'll tell you a story, and certainly in medicine, it's always the unusual patient that will stick in your head. And so I've had this 28-year-old firefighter that came in through the emergency room saying, I am having pain as what the patients that I go pick up as a first responder are telling me they're having. And I just feel like I have something really bad going on there. The guy has no risk factors that we could detect. Looks fit and trim, and you know the firefighters, how they are. They usually are in good shape. And he's saying, I'm having this pain. Well, he comes in, we do troponins, they are negative. And the ER physician is telling me, he's still having pain. He's saying I'm having it. No EKG changes, no troponin elevation. What do you want us to do? And I thought, 28-year-old have not overweight, nothing. This would be an excellent person to get a coronary CT angiography, negative predictive value, 95%. This is the right test to just reassure him and tell him, you should be fine, don't worry about it. Well, we send the guy to the coronary CT suite and we basically do the coronary CT angiography, and I'm looking at his coronary calcium score, zero coronary calcium score, and then looking at his CT angiography, and I can see this plaque in his Prox LED that looks severely tight. And I tried to convince myself that this could be motion artifacts, so I'm moving through the phases of the coronary CT, just trying to clean it up, thinking that if I go to a different phase, it may go away. And it's not going away on any of the phases. And I finally had to say, this looks real. And we send him to the cath lab, and 90% stenosis, Prox LED, in a guy that was apparently having no risk factors that we could detect. Young guy, fit, and everything. And so I believe that coronary CT has a niche place that is no other testing can give you that. Because you can visualize the arteries. It's almost like you gave them an angiogram without giving them an invasive procedure. So I think in this group of people where you have a young person and you just want to tell them there's nothing there, don't worry about it, or if there's a problem, to find it and act upon it, I think in young men, I feel that that's a very good option to do that. The coronary CT angiography, the cost of it is $3,000. So it's actually cheaper than treadmill nuclear. It's cheaper than LexiScan. It's cheaper than PET, CT, cheaper than stress MRI. But the problem with coronary CT is if you have a ton of calcification, the test is not very helpful. And so when you see somebody with extensive plaque burden, I never order a coronary CT angio in those, because I will not be able to give them an accurate evaluation of their arteries, because the calcium acts as if it's like an eggshell. When you have an eggshell, you can't see the inside of the egg, but certainly if you don't have that much calcium, you'll be able to see inside the artery and see where the problem is. So the weakness of cardiac CT is extensive calcification. If you see extensive calcium, there's no point proceeding with that. Another niche area for coronary CT is evaluating the bypass grafts. It's very good at evaluating bypass grafts. So when we have a problem cannulating the graft, or a problem seeing all the grafts and we don't know, does that mean it's occluded or we're just unable to engage it in the cath lab, we get a coronary CT angio, and that helps us tremendously because we immediately will see the bypass grafts, and we get very good results looking at bypass grafts because bypass grafts tend to not move a lot. So we get good pictures and can see inside the grafts really well with coronary CT. Anomalous coronary arteries is another big one too. So if you have a young person, and even young female, because now with the new CT equipment, our radiation dose had decreased tremendously with the coronary CT. You can get, excellent studies with very little radiation. So now we're not as worried about women as we were 10 years ago when I was doing cardiac CT. Any young woman, anybody in their 40s, we did not want to venture that route at all because we were worried about the breast. But now with the new technologies, our radiation dosage with CT has been really low. So this is kind of a quick and, as much as I possibly can give you information about when to use them. So if I want to summarize that, and you just want to remember just those few things, If you have somebody that can exercise, try to always exercise them unless they have a left bundle, a pacemaker, or an ICD. If you have somebody that can exercise and have a normal EKG, just go ahead and do a treadmill exercise test. But if they do have an abnormal EKG, then definitely a treadmill nuclear stress test would be very reasonable in those people. If you have a woman that you are concerned about, she's young, but she's still having symptoms, you're not sure if her symptoms are cardiac or not, stress echo tend to be excellent for those group of people. If you have a younger man that is having symptoms and you've done the treadmill exercise test route and they didn't suffice it, they're still coming complaining, then a coronary CT angio would be excellent to either rule it out or rule it in that they have a problem. And if you have somebody with multiple comorbidities and cannot exercise, then I go straight to PET. Now, I have to tell you that you have to prior authorize these tests. So you have to make sure that your office are prior authorizing these people so that radiology actually do a pretty good job at prior authorizing the PET CTs and the coronary CTs and the coronary calcium score. I have to say that for us in the Heart Institute, I'm not so sure that we are the ones doing the prior authorization. They kind of expect that your offices will be doing the prior authorization for those. And if you don't want to do the prior authorization, that's okay, but you just have to communicate that to them so that the prior authorization is performed and you don't have a problem with the patient getting their test and they have not contacted their insurance for prior authorization.
Wow, that was amazing, Dr. Nassif. A lot of great information, something we're going to have to digest and take in, but that hit a lot of major topics, and I think you did a really great job of summarizing everything. I think primary care doctors all need to hear this. Dr. Sharman, you have questions or anything to add?
Well, I agree. Dr. Nassif, that was amazing. For those of you out there, Mark Johnson and I had come up with over 30 questions to maybe ask. And we could go on for another couple hours with the rest of the questions that we thought about. But that was so thorough and so amazingly useful for primary care that certainly we'll have to have you back. Thank you.
Well, thank you all for inviting me, and thank you to Teresa and to Colton for helping us out with the podcast. And it's a pleasure to be with you today.
Hey, well, thank you very much, Dr. Nassif.
Appreciate you all.
This podcast has been a production of the Ogden Surgical Medical Society. The producers for this podcast are Clark Madsen, MD, MS, Teresa Pesquedra, MPC, and the board of the Ogden Surgical Medical Society. The executive director is Teresa Pesquedra, MPC. Your hosts for this podcast are Mark Johnson, MD, and Steve Sharman, MD. Editing and sound design is by Colton Gomez, and this is all supported by members of the Ogden Surgical Medical Society.